Good evening. My name is Gabriela Teixera. I'm an ocular oncology fellow at Universidad Federal de São Paulo, and today I present a clinical case. The patient is a 50-year-old male from São Paulo who presented sudden and painless vision loss in the right eye for the past 2 months. He denied past ophthalmic and systemic history. His initial ophthalmic exam, he presented light perception visual acuity in the right eye, 20/20 in the left eye. Intraocular pressure was 10 in the right eye and 12 in the left eye. I'll show photos next of the anterior segment of both right eye and the left eye, and the fundus exam was impossible in the right eye due to media opacity and showed no alterations in the left eye. These are photos of the right eye. You can see a small pterygium, an important cataract, and a retrolenticular extensive pigmented mass with some feeder vessels adjacent. The left eye, no important alterations. And here is the ocular ultrasound we requested for further investigation of the right eye. We can see some vitreous opacities, a big heterogeneous mass with mild to low internal reflectivity, and some areas that suggested internal vasculature and necrosis. And adjacent to the lesion, we can see a retinal detachment. The main hypothesis then was choroidal melanoma. Abdominal ultrasound revealed no signs of metastasis, and CT scans of the brain orbits and thorax were requested. Enucleation of the right eye was then performed. The anatomy pathology showed it was a malignant teratoid meduloepithelioma grade 4, measuring 3 centimeters in the bigger axis, and there was invasion of the ciliary body and the choroid. There was no scleral infiltration nor neural or vascular invasion. The immunohistochemical analysis showed positivity for vimentin, GFAP, synaptopsin, enolase S100, CKH18, and KI67. AE1, AE3, and HMB45 were positive in phenoplastic cells, and melan A was negative. This pattern also suggested malignant teratoid meduloepithelioma. These are some photos of the pathology. We can see rosettes, immature blasts, epithelial cells, and also cartilage tissue. The diagnosis then was malignant teratoid meduloepithelioma, and the patient was referred for evaluation with a clinical oncologist and also genetic screening for DICER1 mutation, since his mother had died at the age of 33 due to a kidney cancer. In the follow-up, he presented great aspect of the anophthalmic cavity, and he was referred for prosthetic adaptation. The meduloepithelioma is a rare congenital tumor that originates from the non-pigmented ciliary epithelium. It arises from the medullary epithelium of the inner layer of the optic cup before its differentiation in the embryogenesis. It typically presents in the first decade of life, and most patients are symptomatic, presenting a fleshy melanotic mass. Its secondary complications due to its growth are glaucoma, cataract, and retinal detachment. The tumor can be non-teratoid in the histopathology when the cells resemble the ciliary epithelium, or teratoid, containing heteroplastic elements such as cartilage, rhabdomyoblasts, and brain tissue. And 80% present malignant cytologic characteristics. For the managed, local resection is not advised due to risk of recurrence, and plaque brachytherapy is possible only for small to medium-sized tumors. It presents good prognosis. 9 to 95% present a 5-year survival rate after nucleation. The association with the DICER1 gene mutation was recently discovered. It is a gene from the ribonuclease 3 family located at 14q32.2 chromosome, and it is an autosomal dominant trait. It's associated with the pleuropulmonary blastoma family tumor in dysplasia syndrome, which is a family tumor syndrome with variable penetrance. Not all individuals who present the full characteristics of the syndrome. The other associations are cystic nephroma, sartoid Leydig cell neoplasms, multinodular goiter, and Wills tumor. And it is believed that 3 to 5% of the patients with meduloepithelioma will present this DICER1 gene mutation. To conclude this, the meduloepithelioma is a rare congenital tumor, and it's generally asymptomatic until its growth causes secondary complications. 80% present malignant cytologic features, and this recently discovered association with DICER1 mutation and further studies of the genetic pattern of meduloepitheliomas may elucidate its pathophysiology in the future. These were my references. Thank you.